Hello, I'm Dr. Malescu, and I'm leading you into Chapter 8, Week 4 of Medical Microbiology. So we're going to talk about practical applications and how we prevent infections, mainly non-respiratory infectious diseases. This is just the highlights, as I've mentioned many times, each time we do a lesson visually on this YouTube channel. So make sure that you read the chapter for a comprehensive review. All right, so to highlight the chapter will discuss infectious diseases of various systems in the body, with the exception of the respiratory system. That is an item that we will discuss all by itself. All right, so we're going to talk about the different diseases common. Of course, there are many esoteric diseases that we have no time for at this point. It's just an introductory course. So the most common diseases will be discussed: the signs and symptoms, diagnostic procedures, whether it's blood test, radiography, diagnostic procedure, and then the treatment options, in terms of managing the symptoms. So treatment, I again reiterate, do not use the term cure. We never do. Manage, okay? So treatment will manage whatever symptom it is, and it will manage the particular disease. So the first one is going to be an infection that everyone heard of, and we have vaccinations for it. Now, everyone thinks that viral is probably more severe, but it's not. The bacterial meningitis has a higher mortality, morbidity and mortality. All right, signs and symptoms: fever, nuchal rigidity, which is your neck is stiff, fatigue, headache, declined mental status. Your diagnostic procedure would be, number one, you would start with a blood culture, but this is the go-to, which is lumbar puncture. Obviously, you wouldn't be doing this. It would be a physician that is trained to do the lumbar puncture. So this is a diagnostic procedure. Doing the gram stain and identifying the particular pathogen and getting that CSF culture. So the cerebrospinal fluid is what we're after. If the cerebrospinal fluid is cloudy, there is a chance that there are white blood cells as well as pathogens. So the transmission of meningitis is through respiratory droplets, and the treatment, of course, is antibiotics if it's bacterial. All right, that's the thing. If it's viral, we have to let it run its course and manage the symptoms as best you can. IV fluids, yada, yada, all that. Encephalitis is, unlike meningitis, it's just inflammation of the brain tissue. Meningitis covers it all, right? So brain and spinal cord. Encephalitis is inflammation of the brain tissue. The signs and symptoms will be fatigue, headache, very similar. Abnormal brain function, so that's pretty much one of the main things that you will notice. And if it gets really severe, seizures, paralysis, and abnormal movements. Again, lumbar puncture. Now, this is strictly going to be because of a virus, all right? So if it was bacterial meningitis, we treat it with antibiotics. If it's viral meningitis, we let it run its course. And yes, acyclovir is one of the treatment options for both encephalitis as well as meningitis. The prognosis is death. Yes, it is if it's untreated. So get diagnosed quickly if these symptoms arise. Now, everyone's heard of ear infections. Very, very common. Otitis media, inflammation of the middle ear. The signs and symptoms is irritability, ear tugging, decreased energy, appetite, fever, vomiting. They also can have a loss of balance. That's another thing, right? Because, the semicircular canals along with the cochlea is part of that inner ear, but the middle ear is inflamed, which therefore also can affect the inner ear eventually if untreated. So the treatment is antibiotics, topical steroids to reduce the inflammation internally at the middle ear, analgesics, NSAIDs, non-steroidal anti-inflammatory, that's what NSAIDs stand for, myringotomy, and of course, we want to avoid aspirin due to Reye syndrome. Everyone's heard of that. So that's otitis media. This is how you treat it in children, very common in children. There is an article, you could look it up. There's a higher frequency of ear infections in children that were not breastfed versus children that were breastfed do not get ear infections. All right, moving on to parotitis. So the parotid gland, well, if this is your earlobe, go 2 fingers forward, and if you squeeze, you can actually feel a little bit of a spurt of saliva coming out. Well, that's your parotid gland. And if it's inflamed and infected, it will cause localized swelling of the neck, pain, firmness, difficulty actually swallowing food and water, and yes, high fever and chills, and the treatment will be antibiotics. Next is conjunctivitis, very, very common. The sclera is the white part of the eye. It is also the outer layer of the eye. There's a sclera, the choroid, and the retina. And so the outermost layer of the eye is the sclera. Now, conjunctivitis can be due to allergies if it's non-infectious. It could be due to bacteria, which is quite contagious. And it could also be viral, which is quite contagious and is often preceded by an upper respiratory infection. Now, the treatment is topical antibiotics, usually like an ointment over the area, or drops. And then if it's viral, you got to let it, run its course, do antihistamines and decongestants, and hopefully that's going to help. Warm compresses also help. All right, keratitis is inflammation of the cornea. So this can be due, again, viruses and bacteria, but additionally, parasites and fungi. Yes, they can cause keratitis, and if untreated, it may cause blindness, so immediately get an ophthalmologist. Diagnosis is usually culture. That's how you can find out if it's any of these, all right, virus, bacteria, parasites, or fungi. Okay, now if it is bacterial, an antibiotic is going to be available. If it's viral, it's going to be the acyclovir that we treat for herpes simplex. Now, regarding the antibiotic that's available, it'll depend on what is growing. Okay, so you need a culture. All right. Endocarditis. This is infection or inflammation of the heart valves. Okay, so Streptococcus pyogenes. This causes strep throat. If it's left untended to and you haven't been taking your antibiotics or never got antibiotics, it can get into the bloodstream, travel to your kidneys, damage the kidneys. It could get to the heart and damage the heart valves. So it is not to be taken lightly when someone has a sore throat. So if you have a sore throat, get a culture, make sure it's not strep. And if it is strep, get on antibiotics right away. You do want to avoid infection of the heart valves, or else if untreated, you get mitral valve prolapse. You can get aortic regurgitation due to the aortic valve not working properly. So eventually the patient might end up with valve replacement. So if and when the heart valves do get damaged, then IV antibiotics is required. If the treatment does not occur, death, if it can occur. Obviously, if it involves the heart, yes, it can cause death. All right, so I hope that was informative. Now we move on to the types of catheters that we use. So catheters that we use are related to infections. Why? Because they are a vector. They can, it's iatrogenic infection. You're trying to help someone to get through one thing and then you give them something else. So, all right. So some of the catheters that can cause infection. Let's talk about subclavian catheters, internal jugular, femoral. These are all types of catheters. Signs and symptoms could be redness or purulent drainage around the catheter site, fever, low blood pressure, Change in mental status. How do we find out whether it is the root cause of everything? If it's a catheter-related infection, you needed to get a culture directly from the catheter and from a peripheral vein. So obviously, you're going to have to remove the catheter, all right? Remove the catheter and place the patient on antibiotics. Now, peripherally, it can happen in the arms and the legs, but it is quite rare, okay? Quite rare. It is more common in central areas, the central lines. All right, moving on. Let's talk about cellulitis, something that I saw in my practice a lot. Lower extremity cellulitis usually was either caused by a chronic venous stasis ulcer with poor circulation, but more likely a diabetic ulcer that would get infected, or simply a diabetic that's poorly controlled, stepped on a nail, or even just got a blister and the blister turned into a whopping grade 3 ulcer and eventually an infection with a cellulitis. The cellulitis is usually found in the lower dermis area of the skin layers. So you got the epidermis, the dermis, and the hypodermis, which is the fat. So it actually hits the lower dermis, maybe even that hypodermis, which is the subcutaneous tissue. All right, moving on. Signs and symptoms, very red on the skin. Flat, difficult to distinguish the borders. So usually we would use a something to color the area and see if it's spreading, if it's getting worse. Slow development, unless it's a diabetic, then it's fast, okay? Non-intact skin, so that could include anything from a simple cut to a blister to an open wound like an ulceration. Chronic edema, so someone with venous insufficiency and venous stasis ulcers is a culprit to cellulitis. Obviously, the treatment and drug of choice would involve finding out what is the culprit, what is the bacteria. So if there's an open wound, do a culture. If there's a high fever and a cellulitis, you got to do a blood culture. All right, erysipelas. This is the infection of the upper dermis. So cellulitis is lower dermis. Erysipelas is upper dermis. It involves the upper dermis as well as the lymphatics of the skin. The signs and symptoms, very similar, but not as intense. Similar to cellulitis, but not as intense. Redness and swelling over the tissue above the level of the skin. So it's kind of like raised. So unlike cellulitis, it's flat. Erysipelas, it looks like a hill. There's fever and chills. There's abrupt onset of erysipelas, and the treatment is antibiotics. All right, the one that no one ever wants and everyone fears and clears out the emergency room, necrotizing fasciitis. Now, if it's an anaerobic infection, it will empty the room for a reason, because the anaerobes are very smelly. They smell rotten. It literally smells like rotting flesh. Necrotizing fasciitis, in layman terms, they call it the flesh-eating bacteria. Whatever the case is, it doesn't have to be gram-negative anaerobes. It could be gram-positives. Even Staph aureus can cause some serious damage and rapid destruction of the skin. If it gets into the fascial planes between the muscle layers, it spreads along the fascial planes and goes up the leg. Notice I say leg because that's the most common area, but it can also happen in the arm. Those are the most common areas, cellulitis in lower extremity and upper extremity. Spreads quite quickly up the fascial planes, may even cause compartment syndrome, where there's massive swelling, which then cuts off the blood supply and may cause necrosis of tissue. That is a surgical emergency. That is when you fillet and you make long incisions, 3 for all 3 compartments, anterior, lateral, and posterior leg, if you're working with the lower extremity. All right, these are some of the things that I had to contend with as a podiatrist. Of course, I was doing more than the average podiatrist because I was involved in the wound care industry. So I was doing consults in the hospital, and I worked for a wound care company as well. All right, now let's move on. What happens if this gets left alone and there's no treatment? Well, you can go into septic shock, And sepsis is something that will result in death. So you start off with high fever, tachycardia, low blood pressure, which is called hypotension, mental status changes, decreased urine output, kidney failure. That means we're at the late stages. And of course, the systems are shutting down one by one. Okay, so it's a 24-hour turnover. You can't wait beyond that. I would say 6 hours max, get them in the OR, debride as much of the necrotic tissue as possible, open up the fascial planes and release the fluid. This is something that is very serious, necrotizing fasciitis. All right, now next surgical emergency would be appendicitis. Initially, it doesn't start out that bad, right? So patient will have right lower quadrant pain, some nausea, some vomiting, decreased appetite. They'll think, oh my gosh, I know that the appendix is there, so they end up in the ER. All right, so obviously excision, removal of the appendix, appendectomy, and now we could do it laparoscopically, so it's easy peasy, in and out. Next day, you're going home. All right, going home on antibiotics, unless it's really bad and it's ruptured or you've gotten infected, then you're staying in for IV antibiotics a couple of days, and then you get to go home post-op day 3 or 4, depends, okay? It all depends on the severity and how soon you diagnose the appendicitis. Whoopsie, I went too fast. All right. Again, my mouse is super sensitive. All right. Acute cholecystitis. We used to call this fat, fertile, and 40. Of course, that's not very nice, but in medical school many moons ago in the 1990s, this was the go-to term. Why? Well, because typically a person in their 40s, not typically unless they're, exercising and watching their weight and they're eating properly, but in their 40s, the metabolism slows down, so they become a little bit obese. So fat, fertile, they're still fertile if they're female. Okay, it does happen in men too. Obviously, it's an equal opportunity. But if they're female, it typically happens in their 40s, not early in their 20s. Okay, and it's because as we age, we don't process as well. Metabolism slows down. That depends on the food, the diet. Like I said, if they're obese, they're probably eating the wrong foods, high in oils and fats. And unfortunately, a lot of fatty meat is going to increase the production of gallstones. And so the gallbladder is going to store the bile, which emulsifies fats, but the liver makes the bile. And unfortunately, what happens is stones build up based on the foods that you eat, and the buildup of these stones will block the passageways, is easiest way to explain. And so the symptoms are fever, chills, right upper quadrant pain, nausea, vomiting, lack of appetite, rebound tenderness on palpation of that area. And usually the pain, the patient will actually say, I had a Big Mac and an hour later I'm in excruciating pain. Well, it's probably because the burger had a lot of oil and fat in it, stuff like that. So how do you diagnose it? Easiest way now, we don't even need to do a CAT scan anymore. Gallbladder ultrasound, diagnosis, then treatment. Like I said, laparoscopic removal of the gallbladder, and we call that a lap chole or a laparoscopic cholecystectomy, lap chole for short. And so the gallbladder is going to be gone. And now what happens is the individual, how do you deal with the bile issue to emulsify fats? Well, initially patients are going to have to avoid fatty meals and slowly introduce it, but keep it at a moderate level or low level so that they, don't get sick. All right, so obviously the liver makes the bile, so obviously the liver takes over, so you don't really actually need the bag of bile. Literally, a gallbladder is a bag of bile. All right, so that's that on acute cholecystitis. So we did that. Now let's go over diverticulitis. This is often very common. Again, 40 and 50 years of age, male and female, doesn't matter, but it's inflammation of the diverticula. And if you don't get it treated, your intestine can rupture. You can get an abscess. You can get peritonitis if it's not treated diffusely. The bacteria spread across the peritoneum over the small intestine, and you can die. So severe, you need to get it treated. Diverticulitis, pain in the left lower abdomen, rebound tenderness, nausea, vomiting, constipation or diarrhea. How do you treat it? Antibiotics. If it's caught early, oral antibiotics is fine. If it's caught late, IV antibiotics needed. All right, Clostridium difficile colitis. This is mild to severe and sometimes life-threatening. This is very common in the hospital for patients that are there long-term. Usually it's a history of chronic antibiotic use, probably for more than 10 weeks. And I'm sorry, 10 weeks ago, I should say. So if the patient had antibiotics for 10 days, it can pop up like literally up to 10 weeks, after. All right, so diarrhea is severe, abdominal pain with cramping, low-grade fever, and elevated white count. Leukocytosis means elevated white count. Symptoms obviously is diagnostic and the history of what antibiotics you took. So this is why it's so super important to either get the live culture via the supplements that you can purchase at any health food store, or even now you can get it at any market. So definitely would recommend that. And other people do just eating yogurt, and that's how they get their lactobacillus. Those are the good bacteria that can combat this bad bacteria, Clostridium difficile. All right, infectious diarrhea. This is very common, more common than you think. You can cause inadvertently from having diarrhea. You can contaminate food if you don't wash your hands properly. You can get infectious diarrhea just from traveling or exposure to pets. Definitely exposure to pets. I can assure you I've experienced that. I had a situation where I was at someone's house who had a snake, played with the snake, and I did wash my hands, still had the abdominal cramps and diarrhea all night. So there was nothing else that I could attest it to. So be very aware that pets can get you sick. All right. All right, anyway, it's self-limiting. All right. So for me, it lasted 24 hours, got better, made sure I drank lots of water. So, let's say you go in the outskirts of a country and you're not in a major city. So most major cities, like if you go to Cancun, Mexico, you're good. You go to a nice restaurant or hotel, you're good. But if you go in the outskirts and in the countryside, the water, there is a good strong possibility that the water is contaminated. So obviously everyone's aware of that. So also additionally, wash your hands frequently so that you don't end up with infectious diarrhea. All right, be cautious with the food that you eat and where you're getting it from. Lots of people love to get it off the street. Not the best idea. I grew up in New York City. I kind of avoided that. All right. But some people like those New York hot dogs off the street. So there you go. But there is a risk that you take. And also the beverages that you drink, you could still get infectious diarrhea. All right. The next one, sexually transmitted diseases. Very, very unfortunate that it is very, very common because there's so many of them and so many ways that you can get infected. And all it takes to prevent it is safe sexual practices. Use a condom, make sure it is made of latex. For those that are allergic to latex, this could be a problem. So you got to find other ways. All right, because latex is the best material. Lambskin is porous, and so viruses can get through. Okay. Males are asymptomatic and have painful urination with chlamydia. Mucus discharge from the penis. The incubation period is 7 to 21 days. So 7 days after exposure. Females will have inflammation of the cervix, so they'll have some pelvic pain. Urethritis, inflammation of the urethra. Salpingitis, inflammation of the ovaries and the fallopian tube or uterine tube. Endometritis, which is inflammation of the lining of the uterus, and pelvic inflammatory disease is the late stages. Okay, so what do you do for chlamydia? Good news, it's a bacteria. You don't live with it forever like herpes. Herpes, you're married to it forever. But chlamydia, there's no marriage, there's a divorce. How do you divorce it from your body? Take doxycycline and azithromycin. These are the antibiotics to cover chlamydia. All right, next one down the line, gonorrhea. Gonorrhea be gone. How do you treat gonorrhea? Well, ceftriaxone, that's, these are all not the first generation, but second, third, there's the third and the fourth generation cephalosporins, ceftriaxone, also known as Fortas, cefixime, and azithromycin. Azithromycin, as you know, is a very popular drug. It's not just used for gonorrhea, okay? It's basically your Zithromax. All right, now asymptomatic is what is common, unfortunately. And these are the super spreaders. If they're not practicing safe sex and they like to have sex, they're spreading gonorrhea. So asymptomatic, and it's in the urogenital area. It can also be pharyngeal in the back of the throat, and it could also be rectal if there's anal sex involved. So males and females, doesn't matter. Gonorrhea, you can also have inflammation of the conjunctiva. This is usually young children that get it from the mothers as they're born, right? So the baby is born and they travel through the vaginal canal and end up with this conjunctivitis, gonorrhea. Adults can get conjunctivitis as well. Obviously, young children for other reasons, but adults for sure through sexual practices. You can also, unfortunately, end up with two, not one. It's a 2-for-1 deal. No one likes that. Chlamydia is often together with gonorrhea, so a co-infection is quite common. All right, so there's that. So we went over chlamydia, gonorrhea. Now let's go over the marriage between herpes simplex 1 or 2. If you get herpes simplex 1, it's on the lip, you get a lip sore, it'll be there forever in terms of your body, but it'll only visually be seen on your lip as a lip sore when it's in its active stage. When it's resolved and it's in its inactive stage, it lays latent within your body, only to come out when there's a stressful event. Type 2 is the genital herpes. So it's just a variant of herpes that is going to infect the genitals. Again, just like gonorrhea, you could be asymptomatic and spreading it. But if you're having blisters around the genitalia area, as well as the rectum, you are in the acute symptomatic phase and quite contagious. All right, so outbreaks may occur since the viruses can never be eliminated from the body. The only way to do it is to do acyclovir as needed when there is an acute phase. Excuse me. Let me get a drink of water. I've been talking all day. Next one is HIV. If left untreated, it progresses to full-blown AIDS. All right, so acquired immunodeficiency syndrome. Risk factors, well, we know sexual, how should I put it? Sexual behaviors that are risky, all right? Not using a condom. And there are many ways to prevent infection, but the best way is the latex condom. All right, so STD, due to inappropriate sexual behavior, injection of drugs and sharing needles, receiving blood products. This doesn't happen much anymore since we're very, very super strict with analyzing the donated blood. But in the 1980s and 90s, lots of people got infected with blood products that were contaminated. All right. And unfortunately, has to be added in here, healthcare workers are prone to accidental needle stick, or in the case of even like scalpels. All right. It happened only once for me in the OR, but it broke the glove and a minor opening to the skin. And of course, we had to go through the proper protocol. And everyone, I will tell you, everyone in the healthcare field will be exposed to it once. Everyone has had that one incident. All right. But, you know, it's not that I want it to have happen to anyone, but it's good because then you're super, super, super hyper alert to any possible risk factors. Basically, for me, it was the scalpel was passed to me incorrectly by a surgical tech, surge tech person. So some of you are in that program, a lot of you. So be mindful of that because you don't want to piss off the surgeon. All right. So treatments, antiretrovirals. And if you don't treat HIV with antiretrovirals, it will lead to opportunistic infections that I mentioned in my other lesson, such as Candida, you know, even tumors like Kaposi sarcoma and other multiple infections, lung infections, fungal infections in the lung. All right. So antiretrovirals to prevent progression to full-blown AIDS and opportunistic infections taking over the body. All right, osteomyelitis. I, as a practitioner, podiatric surgeon, saw a lot of this. Diagnostic procedure that I would do is first take a culture, a wound culture, and then I would find out, oh, great, the wound probes to bone. Now what? So I would get a bone biopsy and do a bone biopsy and get a diagnosis that way. All right. So the infection could be in one or more bones of the body. You want to definitely do blood cultures and call infectious disease. You would probably envision not just the bone infected, but the adjacent tissue. There could be accompanying necrosis, definitely erythema, which is redness, pain, which is dolor, okay, edema, which is swelling, fever, chills, all of it. The treatment obviously is debridement, IV antibiotics, and surgery to remove necrotic bone. And what I mean by surgery to remove necrotic bone, I mean amputation if needed, okay? So you amputate to where there is no necrotic bone, and you can do different radiography methods, bone scans initially to see where it's hot, and this way you know where the infection is located, because where it's hot, there's inflammation. You know that infection is inevitably over there as well. All right, and so that's bone infection, osteomyelitis. Now you could get a joint infection where you have to aspirate the joint and get some fluid, the synovial fluid from the joint. And that's what's next. We're going to talk about septic arthritis. You can get a septic joint where you take a large needle. I won't say how large, but suffice to say easily 18. And you're going to go into the joint if it's the knee. It could be the shoulder. It doesn't have to be. Most common, it's the knee. And you aspirate and get the synovial fluid. And if it's cloudy, probably there's some white blood cells there, and perhaps there's some bacteria. The risk factors for septic joint is that you have diabetes. You also have a replacement. So someone who has a knee replacement or a hip replacement is at a higher risk for septic arthritis. The use of steroids, prednisone chronically, and rheumatoid, we already mentioned surgery, right? So we know that, obviously surgery and a replacement like a knee or hip replacement. Rheumatoid arthritis, why? Because this is an inflammatory arthritis, and inflammation chronic inflammation or even acute inflammation leads the joint to become more susceptible to opportunistic organisms of septic arthritis. And of course, very common is IV drug use, that where they share needles and you can get septic arthritis. And of course, if you're just old, advanced age can increase the chances of septic arthritis. Signs and symptoms: painful, swollen joint. So, dolor, erythema, edema. All right. Warmth is calor. These are all terms you need to know. Fever with chills. Pain with movement of the joint. All right. Treatment: IV antibiotics. If it's a septic arthritis, IV antibiotics. Oral is not going to cut it. All right. So, circling back and summarizing what we discussed in this chapter. Will you have to diagnose any of these? No, not unless you're going to be a doctor. But will you be seeing these? Yes, very, very much so. Very common, whether you can be a nurse, surg tech, nurse practitioner, PA, physician. Yeah, for sure. These are the more common infections. All right. So make sure you go over the chapter and understand the clinical presentation, the signs and symptoms, the diagnostic procedures, how to diagnose it, the treatments. All right. And these are all non-respiratory infections, everything other than respiratory, everything else, infections everywhere else, from the head, the neck, the eye. Make sure you understand the cardiovascular infections and how you get endocarditis. Infections of the skin. Remember, we had cellulitis and erysipelas. Intra-abdominal infections like the gallbladder and the appendix, and moving on to genitourinary tracts infections and all the sexually transmitted diseases. And of course, osteomyelitis is bone infection, and joint infection is septic arthritis. All right, I think I'm done. All right, so just make sure you know that initially we do a broad spectrum antibiotic therapy. We call that empiric therapy until we get the proper culture and diagnosis through bone biopsy or wound culture, etc. All right. And as I said, this is just a highlight, so make sure you read the book, go over the text and the tables, and all the information of all the related diseases and treatments. All right, I'm going to stop sharing and say goodbye to you, and I will see you next week for our final 2 lectures. All right, bye-bye.